Hello, my name is Minali Prasad, and I'm a medical student at Boston University. Today, I will be presenting on the association between inner retinal cell layer thickness and plasma glial fibrillary acidic protein. The central nervous system and the eye share a common embryological origin. Eye diseases such as diabetic retinopathy, age-related macular degeneration, and glaucoma have been associated with neurodegenerative diseases. There is an urgent need to diagnose Alzheimer's disease and other neurological diseases during the early stages when symptomatic therapy will have a more meaningful effect. Optical coherence tomography, or OCT, is a non-invasive structural imaging technique that provides high-resolution cross-sectional images and volumetric information about the optic nerve and retina. Existing literature has demonstrated associations between neurodegenerative conditions and OCT biomarkers, including retinal cell layer thickness. Plasma biomarkers, including glial fibrillary acidic protein, also known as GFAP, have been associated with amyloid accumulation and neuroinflammation in Alzheimer's disease. Given the associations between neurodegenerative conditions and retinal cell thickness, we evaluated the association between inner retinal cell layer thickness and GFAP in plasma. This cross-sectional study included 50 adults without dementia. They underwent a pars plana vitrectomy between September 2019 and August 2021. Their GFAP levels were measured by ELISA, and all patients underwent macular OCT imaging. OCT scans were included if they had a quality score of at least 20 out of 25. Scans were excluded if they demonstrated any macular pathology that impacts retinal thickness, including subretinal fluid, intraretinal cysts, and macular holes. Heidelberg Spectralis software was used to determine the thickness of the inner retinal cell layers, including the retinal nerve fiber layer, ganglion cell layer, inner plexiform layer, and inner nuclear layer. We recorded the mean thickness of these layers at each subfield defined by the early treatment of diabetic retinopathy study, as shown on the right. We used multivariable linear regression analyses with log-transformed GFAP as the outcome and inner retinal cell layer thickness as the predictor. All analyses were adjusted for age, race, gender, diabetic retinopathy, glaucoma, and apolipoprotein E4 allele genotype. False discovery rate was used to account for potential type 1 errors. P-values less than 0.05 within a false discovery rate of 10% were considered significant. Our cohort was mostly male, homozygous or heterozygous for the apolipoprotein E4 allele and diagnosed with diabetes. In general, the central fovea tended to be thinnest, followed by the inner macula and then the outer macula, which is consistent with prior literature of retinal thickness in healthy adults. Higher plasma GFAP levels correlated with retinal thinning in the retinal nerve fiber layer at the superior nasal and inferior outer macula and aggregate outer macula. Higher plasma GFAP levels correlated with retinal thinning in the ganglion cell layer at the superior nasal and temporal inner and outer macula, inferior inner macula, and aggregate inner and outer macular regions. And higher plasma GFAP levels correlated with retinal thinning in the inner plexiform layer at the nasal and temporal inner and outer macula, inferior inner macula, and aggregate inner and outer macula. There were no significant associations between plasma GFAP and inner nuclear layer thickness. Overall, higher plasma GFAP was significantly associated with thinning in all inner retinal cell layers, except the inner nuclear layer. To our knowledge, this is the first study reporting a significant association between higher plasma GFAP levels and inner retinal cell layer thinning in patients. However, this contrasts with a prior work reporting a negative association between inner nuclear layer thickness and GFAP intensity in the hippocampus of diabetic murine models. The difference in results are likely due to differences in the source tissue of GFAP. The inner retinal degeneration in our study may parallel the previously reported loss of white matter associated with higher plasma GFAP. Prior work from this research group demonstrated that GFAP is more abundant in eye fluids than plasma. However, plasma may be collected more non-invasively during routine blood draws, whereas eye fluids like aqueous humor or vitreous humor require an anterior chamber paracentesis and vitrectomy, respectively. Future studies could investigate whether retinal imaging markers combined with plasma proteins can serve as tools for screening and risk assessment in neurodegenerative disorders. Thank you for your time, and I look forward to answering any questions at the upcoming symposium.